I'm going to introduce our next speaker. Dr. Leah Ferrante joined us last summer and is a specialist in neonatal neurology and neurodevelopmental disabilities. She did her medical school in West Virginia, her residency in neurodevelopmental disabilities at Baylor College of Medicine, Texas Children's in Houston, and then did a fetal and neonatal neurology fellowship at UT Southwestern. Came to us last year and is helping lead our neuro-NICU and NICU follow-up programs. She's going to speak with us today about the neurodevelopmental outcomes and management in patients with prematurity.
Good morning, everyone. I have nothing to disclose. I first wanted to start off with talking about the scope of prematurity in general. And so in general, 10% of all births worldwide are preterm. And so you're going to see kids that were born preterm. In the US in 2022, the preterm birth rate was 10.4%. And as you can see, in general, the United States is not doing so hot when it comes to preventing prematurity. And we will talk about some of the risk factors associated with it. I wanted to specifically mention that the preterm birth rate in Black people is 1.5 times higher than other races. And as you can see, it's typically the southeast that is unfortunately doing the worst when it comes to preventing preterm birth. This has absolutely nothing to do with the amazing work that our neonatology colleagues are doing. This is strictly preterm birth as an occurrence in general. However, speaking of the amazing work that our neonatology colleagues are doing, 90% of infants between 500 and 1,500 grams survive the neonatal period now. And so what are the risk factors for prematurity? There's a myriad of them. Preeclampsia, being over or underweight prior to pregnancy. IVF is a common trigger for prematurity. I see that quite often in my follow-up clinic. Short time between pregnancies, having diabetes or gestational diabetes. Prior preterm birth, you are much more likely to have subsequent preterm infants. Tobacco use, which thankfully has overall gone down in the United States. Illicit drug use, specifically things like cocaine and methamphetamine. Having a UTI, which is a reason that OBs are checking to see if people that are pregnant have asymptomatic bacteriuria, because that is a risk factor for preterm birth. If a parent is less than 18 years old, or if they are greater than 35 years old, there's kind of that sweet spot of when it's ideal to have a baby. And of course, I could not possibly name every single risk factor for prematurity, which leads us into what are the risk factors for preterm brain injury? There's also a myriad of these as well, including chorioamnionitis, postnatal steroid administration, which we'll talk about a little later, placental insufficiency leading to IUGR or small for gestational age, frequent episodes of apnea and desaturations. There is a lot of research being done recently looking at quantifying how long neonates that are premature are hypoxic and translating that into what their neurocognitive abilities are when they're older. Something that people may not think about are multiples. Specifically, twin-twin transfusion syndrome is a condition that is highly associated with preterm brain injury, especially in the recipient twin. The gestational age and birth weight may have a significant impact on whether that child is at risk for preterm brain injury. Seizures can cause preterm brain injury, and anti-seizure medications may cause preterm brain injury. Now, on this point specifically, I want to acknowledge that there's never been a study yet looking at what harms brains more, the seizures or the treatment. And unilaterally, neurologists would advocate for treating seizures versus just letting them go. However, there is a shift in practice now towards discontinuing anti-seizure medications as soon as is feasible, depending on the reason for neonatal seizures, in order to minimize the risk of preterm brain injury. And so, what are the overall rates of neurodevelopmental disability in this population? And so, when you're looking at many different domains of neurodevelopment, we're usually talking about motor development, social emotional development, approaches to learning, communication, cognition. 60% of very preterm infants are delayed or impaired in at least one of these domains, and 44 to 47% in at least two of them. 1 to 3% of all infants in general can be affected by cerebral palsy, depending on what studies you're looking at. And of high-risk infants, which includes preemies, 8 to 40%, depending on the study you're looking at, develop cerebral palsy. There's also things that are not cerebral palsy that qualify as motor dysfunction, such as coordination issues, as well as having gross motor delays. And that is about at a rate of 40% in high-risk preemies. There was a really interesting study done out of Sweden, one of those countries that has a beautiful population database that they could access and suddenly have millions of patients to look at for data. However, what they found, they used 4 million babies in that database and looked at the overall rates of autism spectrum disorder. And overall, for any preemie, which would be anyone born at less than 37 weeks gestational age, 2.1% of those of those infants later went on to develop autism spectrum disorder. And as you can see, there is a gradation with higher rates in children that are born more premature. Today, I just want to talk about some very common preterm brain injuries. There's many other types of brain injuries that can happen in the neonatal period, in the infant period, while a neonate is ill enough to be in the NICU. And these are what I would say are the most common ones that we see. This is strictly talking about premature infants. There's a whole different subset of term brain injury patterns that I will not go into today. And so the ones that you'll most commonly hear about are intraventricular hemorrhage or periventricular hemorrhagic infarction. If that second term doesn't look familiar, I'm going to explain why. One of the most common is periventricular leukomalacia. I'm going to go into a little more detail about that. And then cerebellar hemorrhage is something that is gaining more and more recognition as a preterm brain injury, where we thought it wasn't as common as we are now seeing it is. So let's talk a little bit about intraventricular hemorrhage. And so talking about prematurity care in general, the most improvement in neonatal mortality has been in the 25 to 28 weeks gestation range, mainly due to an increased use of antenatal steroids when moms go into preterm labor. And the reason I talk about those in general is that not only has it improved mortality, it has also decreased the rates of intraventricular hemorrhage in these babies whose mom get antenatal steroids. Usually you want 2 doses, but 1 dose is better than none. And so the incidence of intraventricular hemorrhage for infants born at less than 1,500 grams is between 20 to 25%. So between a fifth and a quarter of all preemies less than 1,500 grams will have an IVH. The more severe forms of intraventricular hemorrhage, grade 3 and 4, make up about 5% of IVH. And of course, the smaller a baby is, the more likely they will have an IVH, regardless of gestational age. So if you had a 28-weeker and a 25-weeker, and that 28-weeker was small for gestational age and was smaller than the 25-weeker, that 28-weeker would probably have a higher risk of having IVH. Now, why does IVH happen? Well, in adults, when fluctuations in blood pressure occur, our vasculature autoregulates how much of that pressure actually goes up to the brain, and they dilate and constrict as needed to prevent all that pressure from going up straight to the brain. However, in premature infants, that autoregulatory mechanism is either immature or has not developed at all yet. And there are a lot of things that can cause dangerous increases in blood pressure to the brain in neonates. And there's been studies that show that something as simple as a diaper change can cause dangerous spikes in intracranial pressure. And so why does an IVH happen in general? Capillaries that supply the germinal matrix, they're very, very fragile. And so what can happen is all that pressure can actually burst those small capillaries, and the blood can either stay within the germinal matrix, which is commonly referred to as a grade 1. The blood can leak out from the germinal matrix into the ventricles, and I'm not going to go into detail, there's a couple different ways to measure whether something's a grade 2 or a grade 3, but grade 2, in general, less blood. Grade 3, more blood in the ventricle. And we'll talk about grade 4s. This diagram is very technically incorrect, and I will explain why. Grade 4 IVH it was thought that the blood would be pushed into the surrounding brain tissue, and that is not the mechanism that is thought to cause a grade 4 IVH. And it's important to know that the hemosiderin from the blood breakdown will stick around for a while, but it's not something that we need to do anything about. We don't need to re-image kids to quote unquote see how the blood is doing. We know that it's going to resorb. Okay. So overall, when it comes to neurodevelopmental outcomes in these kids, there is a slightly higher incidence of cognitive deficits and cerebral palsy in children that have grades 1 and 2 compared to neonates that don't have hemorrhage. However, grades 3 and 4 will have about a 50% incidence of either cerebral palsy or cognitive deficits. And there is definitely a higher number of children that exhibit deficits when the IVH is associated with other preterm brain injuries. There used to be the thought that grade 1 and 2 intraventricular hemorrhage was nothing to worry about, but there have been a few studies recently that have shown that kids that have grade 2 IVH may have more mild neurocognitive deficits in school as they get older. So periventricular hemorrhagic infarction is the more correct term for grade 4 IVH. And I mean, technically it's not an IVH. It used to be called grade 4, but it's not an intraventricular hemorrhage. However, it is associated with it. It is actually a venous stroke that is caused by the ventricles dilating from the intraventricular hemorrhage. That blood impairs the cerebrospinal fluid from resorbing. And what happens is the ventricle puts pressure on terminal medullary veins, inhibits that venous drainage, which leads to a stroke. Now, not all of these are created equally. There's actually a whole grading system just for teasing out different severities of grade 4 or PVHI. Now, when it comes to talking about outcomes for PVHI, there used to be this thought that as soon as a kid was diagnosed with a grade 4, that's it, it's over, this kid's not going to have any quality of life. And we are finding that actually that is very much not true. And it is important to acknowledge that a fair number of these preemies do die, but it's not because of the grade 4, the PVHI. And so a couple of studies have been done looking at the outcomes of these children. In one study, 30 children had PVHI. 61% had an abnormal neurologic exam consistent with cerebral palsy. In another study that looked at more factors, out of 74 infants, 31, or 42% of the cohort, had cerebral palsy. However, when you looked at the kids that had cerebral palsy, 25 out of the 31 had a gross motor function classification system level of 1 or 2, meaning that 81% of the kids that had cerebral palsy were able to ambulate without assistive devices. As for cognitive outcomes, mean cognitive outcomes on the Bayley scales at 2 years of age was about 95, which is in the average range. Sure, statistically significantly lower than kids that didn't have grade 4 IVH, but if you took a kid that had a Bayley score of 95 and a child with a Bayley score of 110, you couldn't really tell the difference between them in class. But that also means that 65% of those kids had a normal cognitive score on the Bayley scale. Another 23% was in the subclinical range, meaning that they needed to be followed closer to make sure they didn't kind of slip behind, and so that we didn't miss a window to intervene. And only 12% of them at 2 years of age had clinical cognitive deficits. And so I say all these things both to raise your awareness to look for these things, but also to make sure everybody knows that just because you have this diagnosis, that's not the end of the line. Periventricular leukomalacia. I feel like before I did subspecialization in fetal and neonatal neurology, I always felt like this was kind of a nebulous term, periventricular leukomalacia. And the reason why it seems kind of nebulous is because there's multiple different kinds of it. And all it means, periventricular white matter injury. And pathologically speaking, it has two components. There is the focal necrosis that's more visible on the imaging when you see those periventricular spots. If you were to put that under a microscope, it would be completely devoid of cellular components. But there's also more diffuse white matter abnormalities that are associated with it that are not necessarily picked up on MRI, but can affect kids in the long term. And so, in general, the premature brain is very susceptible to hypoperfusion. And so, again, with that immature vasculature, if the baby's brain is not getting enough blood flow, the vasculature is not able to compensate for that. And the other issue is that the white matter in in premature infants is even more susceptible to injury than usual. And so the way I think about it is that NICU babies in general, for most things, they kind of take this Goldilocks approach. Not too much perfusion, not too little perfusion, just right. And that is the ideal way to avoid preterm brain injury. Sometimes the focal areas that are affected do turn into cysts, and sometimes they don't. Focal cystic, PVL, occurs in less than 5% of neonates, and this type of lesion is most highly associated with cerebral palsy. And so on this imaging, you can see a couple of these spots here. Arrow sign, of course. Now, these arrowheads are actually cysts here, whereas these arrows actually are showing the focal necrosis. Cerebellar hemorrhage is becoming more and more recognized, and Now that term equivalent MRIs are being done more in NICUs, we are discovering that kids that are born at less than 32 weeks gestational age, 30% of them have a cerebellar hemorrhage. And the cerebellum has even less capacity to autoregulate than the cerebrum, meaning that it's even more susceptible to hemorrhage and to ischemia from blood pressure fluctuations. In general, studies have ranged from 30 to 100% of infants in the study with some sort of neurological deficit, which could include gross, fine motor problems, movement disorders, even cerebral palsy. Something that's extremely interesting is that there has been a lot of work looking at the cerebellum recently and its role in social behavioral functions and cognition. And ex-preemies that have a history of cerebellar hemorrhage, in one study, 35% of them had autism spectrum disorder at 2 years of age. These are other things that can be associated with neurodevelopmental disabilities that are not brain injury specific. Just having bronchopulmonary dysplasia or chronic lung disease by themselves are risk factors for having a neurodevelopmental disability. Postnatal steroid exposure, some people may know of it as what's called the DART protocol, where if an infant is still intubated after a long time, you try to use steroids to get the child off the breathing tube. There is a 25% increase in risk of that child developing cerebral palsy. So that is a red flag for me whenever I see that in a child's summary from the NICU. And then it's also been shown that necrotizing enterocolitis by itself is an independent risk factor for neurodevelopmental disabilities. So what are some red flags that pediatricians or family medicine physicians could look for in this high-risk population that are red flags to neurologists? If you ever hear that a child shows a hand preference, they are always using their right hand to reach for things, that's a big red flag. If there's early rolling over, less than 2 months old, you hear parents are so proud of their child for meeting milestones really early. It's not always a good thing. So that's a big red flag. Something that I see commonly is that kids will keep one hand or one leg kind of clenched closer to the body than the other, especially if someone's holding the baby and playing with them. You'll notice that one side of their body doesn't move necessarily as much as the other side. Again, rolling over preferentially to one side is a red flag. Persistent feeding issues may be a red flag for a preterm brain injury, including coughing, choking, aspiration. A lot of these, I acknowledge, are looking specifically for concerns for cerebral palsy. And I mention these specifically because it is very rare that infants present with high tone, that classic spasticity that is associated with cerebral palsy, before 6 months corrected age. And so these are almost surrogates to look at how the child is using that one side of the body versus the other. Uneven developmental delays are a red flag. And when I say that, what I mean is that, sure, maybe the child is delayed across the board, but if some areas of development are much more delayed than others, something very classic I'll see is the child is overall delayed, but their gross motor skills are way further behind than the rest of their skills. That's a big red flag for me. And then something else is persistent primitive reflexes. That is a component of cerebral palsy. One thing that I will see is when kids get beyond 7 months corrected age, if I see that they have a persistent plantar activation reflex, that's a red flag, and I'm watching that child very closely. What are some things you can do prior to that child getting in to see neurology? First things first, Stop correcting for prematurity by 18 months chronological age. There's this myth that you need to correct until 2 years old. Honestly, correcting, it's been completely arbitrary. There is no rhyme or reason to it. The reason why why most places stop correcting at 2 years of age is because that's when their early childhood intervention program stops correcting. One thing that Texas does right with this is that they stop correcting earlier, and that's good because then developmental delays become obvious earlier. So stop correcting for prematurity by 18 months. Refer for therapies, private or ECI. Some therapy is better than none. If you're not sure, I always err on the side of referral to therapies because the worst that can happen is that they get evaluated and the therapists who are experts, they say, you know what, I'm not concerned. Come back to me, we'll reassess in a couple months, or if you have further concerns, let me know. And if there's no MRI brain without contrast, you can consider ordering one based on symptoms. And if the MRI brain is ordered close to the time of the visit, the neurologist is happy to go over it with the family. Symptoms that you should be especially concerned about that will likely have something on the brain MRI will be asymmetries specifically, either right side versus left side or upper extremities versus lower extremities. And at Dell Children's specifically, we have a wonderful NICU follow-up clinic. This is our whole big team. We have Stacy Mann here, who is our wonderful nurse practitioner with neonatology, who sees just about every single one of these babies. But we also have a parallel track with neonatal neurology, where we have neurodevelopment integration, so that if anybody is seen by the neurology inpatient team, they are followed outpatient in that track. But also, if there's anybody in the NICU follow-up clinic that is showing signs or concern for preterm brain injury, we work closely together and they get referred over to the neurology pathway by the neonatology side. Here are my references. Any questions? The question was, in the absence of other red flags or anything else concerning, should grade ones be followed or referred for neurology? That's a fabulous question. Right now, there isn't a lot of evidence that grade 1 causes long-term neurodevelopmental disabilities. However, that area is very important for inhibitory neuron growth. And I suspect that in years to come, there will be a lot more long-term follow-up outcome data, maybe to support that maybe someone should be following these kids. I don't know if necessarily neurology is the right subspecialty for it, but as of right now, not necessarily unless other issues pop up. Yes.
So that's a good question. It sounds like you're tied to a follow-up program. Why don't you do the study? It's like you don't have the data. My question, I was intrigued by your comment about rolling over being potentially public. Why? What's the background mechanism?
Yeah, so I talked about early rolling over being a potential red flag. The reason that that's a red flag is that, thank you, ETK, demonstrating it. So cerebral palsy, when it's formed from preterm brain injury, it's not something happens and it automatically just continues going forward. What's happening is those circuits are being rewired, and even though we're not seeing the spasticity yet, there's abnormal connection that shouldn't be there between motor aspects of the brain. And so you may not see tone yet, but it could be that the child's tone is increasing. And so what's happening is that they are rolling over because they're log rolling, because they're not able to bring their hands up as well to stop themselves from doing that. Did that answer your question? Okay.
Have they looked at is there any studies that have looked at the cognitive outcomes in like premature kids with CP versus kids who are born at term like, you know, with CP? Because there's like 1 to 2% you said, but the prevalence is higher in the premature ones. The levels of cognitive deficit, is there
Yeah.
any differences?
That's a great question. A specific study about that, comparing term versus preterm, off the top of my head, I don't know, but the thing that makes it more difficult is that the causes for CP are different between preterm, kids that are born preterm and kids that are born term. Most common term reason for developing cerebral palsy is hypoxic ischemic encephalopathy versus preemies, a lot of it is PVL. And so I don't know if they've looked head to head at that.